So we're going to talk about allergies, mostly about for children, but a lot of this pertains to people of all ages. And when we say allergic rhinitis, that's basically the medical term for hay fever that people mostly use, or people sometimes just say allergies. And so first I just want to talk a little bit about how common is allergic rhinitis, and it's very common, right? The statistics say that 10 to 40% of the population have it at some point in their life. It's up to 40 million Americans. It's the most common disease worldwide, and estimated cost $2.7 billion per year. Most people who get allergies have it their whole life, and it's increasing. Worldwide, there are increases in the rate of allergies. And a lot of people who get allergic rhinitis also get asthma. And that also makes people, it means that they're more affected by having allergies if it's associated with a second disease like asthma and breathing problems. Okay, so the symptoms that people typically get is their nose is itchy, people are sneezing, runny nose, nasal congestion, the eyes may be red or itchy or tearing. The palate, the throat may be itchy, or there may be what we call postnasal drip in the back of your throat, and cough. So these are the different triggers, or some of the different triggers over the seasons, right? Because a lot of allergies are seasonal. So, and they're color coded. So in red in red is springtime, and that's when trees start to pollinate. Late spring, early summer in yellow is when the grasses start to pollinate. And then late summer, actually about now, definitely now, the ragweed, the weeds start to pollinate. And then starting later summer, early fall is when the outdoor molds start to be a problem until the first frost. But some allergens are year-round. This is a picture of a dust mite. These are cats, obviously, and these are examples of year-long exposures. Okay, so there are other things also that could cause hay fever or allergic rhinitis. So these are some of the examples here. Cigarette smoke, pollution from cars, traffic, buses, exhaust. Volatile organic compounds, sometimes we say VOCs, ozone, chemicals for sure, like formaldehyde. Ergosterols and glucans are actually products on fungi and bacteria, and exposure to them also can trigger allergic rhinitis. Okay, so when the medical organizations, they like to classify allergic rhinitis into different types: intermittent, persistent, mild, and moderate to severe. And it's based upon how frequent somebody has symptoms. So if you only have symptoms a couple of days a week, it's considered intermittent. But if you have symptoms more than 4 times a week, it's considered persistent. And then persistent could be mild or moderate severe. So if allergic rhinitis, if you don't have any problems with sleeping or working or sports or going to school, it's considered mild. But if you start to have problems with sleep, with learning, with concentrating, or bad headaches, or other troublesome symptoms, it would be classified as moderate or severe. Okay, so, why people may think runny nose, no big deal, right? But there's actually a lot of complications that are associated with that. It can affect your sinuses. Some people get polyps, growths inside their nose, ear infections, hearing problems. And if it's young children, they can actually, their face and their head can actually develop a little bit abnormally. And I have a second slide about complications. So we talked about this. It could cause asthma or just make asthma worse. Problems with sleep apnea, problems with snoring and waking up at night with trouble breathing while you're supposed to be sleeping, or just generally drowsiness or sleepiness during the day, in part because maybe you're not sleeping well at night. Problems with learning, problems with thinking, cognitive function, being less productive at school or at work, and also some people with allergic rhinitis are also susceptible to some food allergies. So this is a slide, this is a graph of how having allergic rhinitis can affect sleep. All right, so these are patients who have moderate or severe, and you can see in white are people who have persistent allergic rhinitis, and in black are people who have intermittent. Okay, and so people who have more severe are more likely to have problems with not feeling rested when they wake up, not sleeping well at night, or difficulty falling asleep. And this is this graph that shows the effect of having it on your daily activities. And so these are, I think these are adults on this particular slide. But again, white is people who have persistent or more severe allergic rhinitis, and in black are people with more mild. And if it's more severe, you're more likely to have problems with outdoor activities, work, sleep, going out, visiting friends, sports, vacations, indoor activities, and public transportation. So all these categories, people are affected. So this is kind of an overview of how we treat it, and it may be a little bit technical and the writing's a little bit small, but we try to make a diagnosis. We try to categorize it. Is it intermittent? Is it persistent? Is it mild or moderate or severe? And depending upon the category, the medicines that we use will differ as well. So if somebody just has some mild allergic rhinitis, we may only suggest an antihistamine like Claritin or something. But if somebody is more severe, the medications that they need are going to be much more severe, and they may need more than one medicine. And if they're still having problems, they really should be seeing an allergist, and that's represented here. We also try to tell all patients to avoid their triggers, and we'll talk about that in the next slides. And some people have conjunctivitis, which is basically a term for the allergies in the eyes, red eyes, and they may need specific treatment for that. And then if patients are still having problems, they may need allergy shots. And the medical term we use is called immunotherapy. Okay, this is another way of what we try to do when we try to make a diagnosis. Sometimes it's not obvious. So we take a history. We talk to patients, see how they're doing, what their symptoms are, what their triggers are. Is it related to a particular pollen season, spring, summer, or fall? If it occurs every spring, we think they may be allergic to trees. What makes it worse? What makes it better? What do they look like? Do they have inflammation in their nose or their eyes? And likely we would do allergy skin tests. And the point of the allergy skin test is to try to pinpoint more specifically what's causing the symptoms. Is it grass? Is it the dust? Is it the cat, or a combination? Sometimes we don't do the skin test, and we'll do an in vitro test, or basically a blood test. We generally prefer skin tests, but in some situations a blood test may be better. And we try to match up what people are saying about their symptoms to what the test says to get an idea of really what's causing their problems. So this is a picture of allergy testing. It kind of looks like this, but we do a prick test and an intradermal test. Prick test we also kind of call the scratch test. Or we may do a blood test where we measure a molecule called IgE, and it may be like a cat IgE or a mold IgE. And we try to pick the blood test based upon what patients are telling us when we talk to them. And this sometimes come up, how young can you test somebody? So if you have perennial symptoms, meaning they're year long, you can start testing children at the age of 1 or so. If the symptoms are seasonal, we generally recommend you start testing at the age of 2, so that a young child has gone through 2 seasons. The tests usually work out better that way. Okay, so this is a summary of what I mentioned. First we talk to patients, see what's causing their symptoms, then maybe we'll do the skin test, and then with this information we'll usually advise patients on what they can do to try to control or minimize the exposures that they have. If this is not good enough, then we will recommend medicines. If that's not good enough, we may recommend allergy shots. All right, so one of the things we do is we talk to patients and we try to give them information about the environment. As I mentioned, the trees typically pollinate March through June. Grasses May through June or July. Weeds start about now through the first frost. And so if you get a sense of when your symptoms are, you can also get a sense of what may be triggering it. All right, so you can also go online or get an app to actually get the pollen counts. And some people like to do this. This is an example. You can actually go to the National Allergy Bureau, and the closest center is at Fordham College at Lincoln Center. There's a device there that will actually collect and count the allergens, and you get a readout kind of like this. And so if you're worried, are the tree pollen high today, it's April, it's springtime, they will tell you actually which tree species, is it maple, is it oak, is it elder, are elevated, and give you an idea of how elevated it is. Because this particular report is in April, it's too early for the ragweed to be pollinating, and it's really on the early side for the grasses to be pollinating too. And for whatever reason, this particular day they didn't count the mold, which sometimes happens. So a couple of places where you can find this information. I recommend the National Allergy Bureau, but you can download some apps. Some of the drug companies have apps. And there's a Twitter feed from the Fordham Center. Okay, so here's a list of some specific things you can do if you have allergies. So in general, if you're allergic to pollen that's outside, you want to keep the outside pollen outside and not have it inside, so that when you're inside, you're not exposing yourself. So that means things like closing the windows. If you're outside a lot, you're in the park, during the season when you're allergic, when you come home, you should shower and shampoo. All right, so you're washing the allergens off your body. I also recommend, it's on the slide, that you don't wear your shoes around your home, around your apartment, so that you're not tracking in the outdoor pollen. You're leaving the shoes at the door and you're walking around your apartment in your socks or slippers or whatever. You can get a air filtration system with a HEPA filter. Some people actually recommend wearing sunglasses more often, that would actually help with the eye symptoms. Now, specifically, if you're allergic to mold, it's good to get rid of the mold as best you can. Not have moisture, right? Because mold is a result of moisture. So if there's leaks, it's good to repair them. But also to keep the humidity in your apartment relatively low, like less than 50%. Okay, so here are some pictures, of course, of various trees. This is cedar, red cedar. These are all Central Park, birch, oak. So, truthfully, if you're allergic to one type of tree and not the other type of tree, it's actually good to know what these trees look like, especially if you find it interesting. Maybe some people do, some people don't. Okay. So we're going to talk a bit about medicines now. So there's a lot of different types of medicine to treat allergic rhinitis, right? So a lot of people use oral, by mouth antihistamines. And generally, it would be what we call the second generation ones, like Zyrtec, Claritin, Clarinex. And we consider them, they work well and they're very safe. The older antihistamines around, like Benadryl and Atarax, they work pretty well too, but they definitely make people sleepy. And that's a problem, because if you're sleepy, you're going to have problems at work and you're going to have problems at school. So we generally don't recommend the older antihistamines, but we recommend the newer ones. Another way of treating is by steroids, sprays in the nose, because that's where the pollen's going and that's where the inflammation is. So it's actually arguably the first thing you should do. It works very, very well and is very, very safe. And then there's other types of medicines for the nose, something called ipratropium, also called Atrovent, which is also a nose spray, and that works for allergies. It also works for runny nose that's more, has other triggers that's not necessarily allergy related, like vasomotor, like irritant induced. More medicines that people use, oral decongestant. So this is like Sudafed, for example. And it's really not recommended for young children at all, because it's stimulant, and not in a good way. So you want to be careful, because if you go to the store and you see the name pseudoephedrine, it suggests that it has a stimulant in there, and actually teenagers have been known to abuse it and use it to actually make compounds that are like methamphetamines. So now sometimes some of the drugstores, like you go to CVS, they have it behind the counter so that teenagers are less likely to get in trouble with these things. So you want to be aware of this, and it's just generally not considered safe or recommended, even though it has historically been around a lot. Another medicine that's used is montelukast, which is also known as Singulair, which is a very popular asthma medicine. And it turns out that it works very well for the nose also. Okay, so we give a lot of treatment of the nose, since that really is where the problem starts. And we also give steroids to the nose, because that's really what cuts down the inflammation with these steroid sprays. There's a lot of them out there. Fluticasone, which is also known as Flonase, but a whole bunch of them. Sprays or even drops. And they work really, really well. Actually, nose medicine also helps with the eye symptoms. And patients report that they feel better, the quality of life is better, it's safe. And so it can work very well, especially for nose symptoms and for eye symptoms. Also, you can give antihistamines directly to the nose instead of taking a pill. These are some example, acetylestin and olopidine. And they work very well, they work very quickly, but they don't really treat anything other than, say, the itchiness of the nose. They won't do anything for the runniness of the nose, for example. Another medicine available, they're called Cromins. Here are some of the medical name. And their advantage is that they're really, really safe. They have 0 side effects, but they don't work very well, and you have to use it 4, 5, 6 times a day. More nose medicine, something called anticholinergic, which is again the Atrovent, or the medical name is here Ipratropium. It works very well for runny nose, but it can kind of dry it up. And some people worry about glaucoma. So if you have glaucoma or you're at risk for it, you would not want to be on this type of medicine. And then also decongestions of the nose, and actually these are a big problem, and that's why I put this on the slide. So the medical names are ephedrine and pseudoephedrine, and people have liked them because they can really, they vasoconstrict, they really dry things up, and they make your vessel small, and it cuts down, they work really fast, and they cut down on the congestion very fast, so people like it, but there's an overuse problem. And if you use a decongestant for the nose more than, say, 3 days in a row, you can get something called rhinitis medicamentosa, which basically means that you are even have a worse nose than what you started with. And that can cause a lot of problems that are very difficult to treat. So in general, when it comes to decongestions of the nose, so an example would be like Afrin. We really don't recommend it unless a special circumstance, say like somebody's flying in an airplane, right, and they just need it for a day to get through that flight. That may be totally appropriate, but never more than 3 days in a row. So this is more slides about the antihistamine pills. I said that we use the newer ones called second generation. These are all the medical names. This is Allegra, this is Zyrtec, this is Clarinex, this is Claritin. So names you're familiar with, but we don't recommend Benadryl or Atarax because of the drowsiness. And they work very well. They work for the nasal itch, the sneezing, the runny nose. They work for eye symptoms. They work pretty fast. They generally work better to help your symptoms at that time, but they don't do anything to prevent symptoms from coming back. I mentioned the montelukast or the Singulair, which can work pretty well. And it works well for the nose in addition to asthma symptoms, but it doesn't work that great for nose. And some people have complications like rash and this weird syndrome called Church-Strauss. And that doesn't work, then we may think about allergy shots. We call this immunotherapy. There are 2 types of immunotherapy. There's allergy shots, and then recently there's the medicine that you can put under the tongue. So we'll talk a little bit about the allergy shots in a moment. So in research studies, using really good approaches called with placebo and blinding and things like that, a good study design, allergy shots have been shown to work very well for people who have severe allergic rhinitis. And when people review the literature and they look at all the papers that have been published about allergy shots, studies clearly show overwhelmingly that they work better than not treatment in terms of helping with the allergies. Also, there's some research that suggests that giving allergy shots may actually lower the likelihood that someone will have worse allergies or new allergies in the future, and they may even prevent the onset of asthma. Okay, but we also have medicine that goes under the tongue, and there's 4 different varieties, and they can treat grass allergy, ragweed allergy, and dust mite. This is a big chart, and I don't really mean to go through it, but these are the under the tongue forms that we have for treating allergies. These 2 here, Orlair and Grass Tech, are for treating grass allergy, and this one's for treating ragweed. And we don't have a 4th column, but there's a new one now, just for a few months, for treating dust allergy. Each of these only treat one type of allergy. So if you're allergic to dust and grass, you can't do this. It won't work for you. You can't take 2 pills under the tongue. It just does not work. The other thing I want to point out is that this is the one that's approved for children with grass allergy. This is the only under the tongue variety that children can take. And the other thing I want to point out is that they also have other ingredients, right? So this one, for example, actually has fish in it. So you need to know this, or hopefully your doctor does, because if you happen to be allergic to fish, you should not get this medicine or this medicine. So there's a lot of other little components to it that people who are prescribing and taking it need to be thinking about. Also on this slide is that for most of these, you have to start the treatment before the allergies begin, a few months in advance. So then this is the pill, this is the shot, and this is the pill under the tongue. And so a lot of people wonder, well, which one should I get for my allergies? And in general, people rather not have shots, obviously, right? You got to go to the doctor, it hurts, you have to pay a copayment, all these things. So you might rather avoid it. But when you compare the 2, in general, the shots are probably better in particular ways. They work better. Patients, they stick with their program better, and if you have more than one type of allergy, the shots are better. However, when it comes to safety, which is of course important, under the pill is probably a little bit better, and some people think that having medicine under the pill that you can take at home every day is more convenient, and so it gets extra points for that as well. We think that people who have asthma can do well with allergy shots because it can actually help treat their asthma. So it's not just for no symptoms, it can also be for asthma symptoms. And then a bunch of research studies have shown that the allergy shots not only work for the allergy and allergic rhinitis, but it works for asthma. And I think, I mentioned this, but it's an important point that the allergy shots for allergies to the nose, allergic rhinitis, may prevent later asthma. So this is particularly important for kids. You can see here each row is a different study, different kids by ages, and each study is kind of small, but when you put it all together, it's the same message that getting allergy shots versus not is more likely to, or not getting allergy shots when you have allergies is more likely to be associated with getting asthma later than otherwise.